want to open up by thanking you all and thanking you for joining us on this inaugural Blood Advocacy Week. As you are probably aware, Blood Advocacy Week is really an opportunity for a variety of people and organizations to come together in support of a safe and available blood supply. In today's events, we are really going to focus on some limitations that there are in patient access to blood, and really focus on some ways that we can expand access to blood that will really impact patients' life in a very important way. That's both getting patients to blood before they get to the hospital, which can be truly life-saving, as well as palliative transfusions for patients that are enrolled in Medicare's hospice benefits. A reminder, this virtual event is being recorded for future playback throughout the event. If you have any questions, you can absolutely put them into our Q&A box that you will see. And if we have some time at the end of the presentation, we will be able to present those to our speakers. The recording will be available on the Blood Advocacy website in a couple of days after this call is concluded, if you want to go back and look at them. And I'm really excited to introduce to you Audra Taylor, who is the Director for Blood Operations for South Texas Blood and Tissue, and she's going to provide a little bit of background of what their center is doing to ensure pre-hospital blood is available. Additionally, on this call, we're going to have Mary Homer, who is the Chief Project Officer at the U.S. Department of Health and Human Services, to talk a little bit about the work that they are doing in that pre-hospital blood space, as well as Eric Bank, who is the Assistant Chief of EMS for Harris County Emergency Services District 48, and does fantastic work in really serving patients that need blood in that hospital space. Then we will move on to the hospice issue, and Dr. Jennifer Holter, who is a professor of medicine in the section of hematology and oncology, and an adjunct associate professor in radiation oncology at OU Health, will talk about the fabulous work that they are doing in serving the Medicare beneficiaries that in so many places don't have access to palliative transfusions. Well, then you'll have to hear back from me again. I'm Diane Kalmus. I am the Senior Director for Federal Government Affairs here at ABC. And I will go through what we are working on at ABC to advocate to the Hill to really increase access for these patients. Then we will have some time for Q&A. So at this point, I'm going to turn the presentation over to Audra Taylor to present about what their center is working on.
All right, let me get the right screen here. All right, good afternoon. Can you see my screen, Diane?
I can.
Oh, okay, good. All right, good afternoon, everyone. I'm Audra Taylor. I'm the Executive Director for Blood Operations here at South Texas Blood and Tissue. I want to first thank ABC for the opportunity to participate in this inaugural event. What a great opportunity for us to come together and have some of these discussions to hopefully facilitate change in the environment that we are advocating for. Oh, hold on just a minute. Hang on, Diane, I'm having a technical difficulty to advance the slides. Maybe I'll just do it that way. All right, we'll just do it that way. All right, so for the next few minutes, we just really want to take a look at our program here at South Texas Blood and Tissue, discuss our recipe for success, and highlight our next step in the disaster preparedness process. And we know that this is a theme that everyone can relate to as we continue to support disasters one after another during this time frame. This topic is very near and dear to our hearts. So access to blood when a patient needs it matters, but currently there are some limitations that mean patients don't have access when it matters the most. Before a patient gets to the hospital, at the scene of an accident or in an ambulance, blood can mean the difference between life and death, a healthy recovery, or long-term disabilities. For patients at the end of life who rely on a palliative transfusions, it means that they must decide between holistic care of hospice and the quality of life provided by those transfusions. Although remote resuscitations often constitute the most profound cases, just due to the distance and the definitive care, transfusions in urban areas have resulted in marked increase in life safety and a large percentage of total pre-hospital transfusions. The bottom line is it all matters, and we need the right product in the right place and at the right time. So the military's effective use of whole blood transfusions in World War II, Vietnam, and the Middle East conflicts really serves as the basis for the program here in the South Texas area. Retired military surgeon working as a civilian, Dr. Jenkins, collaborated with Elizabeth Waltman at the Blood Center, along with Dr. Gomez and Mr. Eric Epley with STRAC, in order to form the foundation of the program that we have here today. Since a dedicated donor base serves as the foundation for a successful program and its subsequent proliferation, the Brothers in Arms program was established here at South Texas Blood and Tissue. And that was really started to target the desired donor that we need in order to support a program of this magnitude, and really ensure that these donors become a part of that program so that we can continue to maintain our supply throughout our region. The rotational program between EMS agencies and local hospitals has actually led to a 99% transfusion rate. And while the program began with air med providers, it has now expanded to over 20 local agencies. Along this journey, the American Associations of Blood Banks, or the AABB, as it was formerly called, did issue a standard 5.15.1 for the emergency release of low titer O whole blood, which greatly enhanced this program. We are also involved in the BERC group to ensure that we are able to respond to emergency needs as they arise. And that's a collaborative group of hospitals that really work together to make sure that we're able to respond to emergencies. And then just this year here at South Texas, our BIA, our Brothers in Arms program, is now the Heroes in Arms program, as we now welcome women to participate in this very important life-saving program. Over 2,000 pre-hospital transfusions in South Texas have taken place since the program inception in 2018. So what exactly is our recipe for success? Well, a few things are very critical and must continuously take place to ensure that this program that we've established here remains very robust, and we can continue to grow if necessary. So on the infrastructure and support, I just previously highlighted the tireless effort of Dr. Jenkins and the Whole Blood Academy, very important to that infrastructure and support, as long as the collaboration with Ms. Elizabeth Waltman here at the Blood Center and additional Blood Center leadership. There are founding EMS collaborators, validated coolers on board, all of these platforms, as well as blood warmers and a helipad. So all those kind of support our infrastructure for the framework of this program, which we continue with today. Also very important to our recipe are the communications and the rotation of the inventory. So that communication and inventory awareness is very robust and necessary to ensure that everyone knows what's going on, where the units are, and to ensure that we're able to respond within minutes to a disaster. And also the rotation that the EMS and the STRAC team have worked out to ensure that those units get rotated where they need it. Resupply happens as efficiently as possible. Very important to this recipe. The robust donor recruitment program. I already discussed briefly our Brothers in Arms program, which is now our Heroes in Arms, which we say HIA. Very important to have a dedicated group of donors that are committed to this program. So South Texas Blood and Tissue really prioritizes this program, and we feel it's very important that these donors know what they're participating in, and they will continue to support. They all like the membership and being a part of this group, so our goal is to continue to grow this donor base this year and in the years coming. And then finally, that community engagement, very, very necessary to ensure that this program remains on the forefront. So on a regular basis, our teams here at South Texas Blood and Tissue, our EMS leaders, our hospital leaders, and regional state coordinators, they meet on a regular basis to discuss the program, address issues as they surface, and just continuing to keep that communication moving forward. All right, so let's talk briefly about our resupply missions, which here actually happen in a variety of ways. There's not a one size fits all as we try to keep the inventory moving around. Some of our EMS agencies come to South Texas Blood and Tissue 24 hours a day, 7 days a week, 365 days a year. On other times, and with some of our other customers, the South Texas Blood and Tissue team will transport blood to the outlying ground units as operational conditions warrant. And then our air medical providers will actually use our helicopter pad located right across the street from our donor pavilion and resupply prior to returning to home base. So several resupply efforts going on a regular basis. And as we respond to an emergency, that resupply might happen from ground EMS to ground EMS. It just really, really depends to what is going on. So the group remains very, very ready to respond and to coordinate that resupply as necessary. And I apologize for the background noise. I think we have some grounds work going on in the background. So just to continue on kind of with that structure and the framework, regional plans and memorandum of agreements have been adopted by stakeholders to improve the daily process and prepare for mass casualty incidents. Those agreements are in place and continue to this day. And members are empowered to take a proactive steps to anticipate any situational needs. Using this week as a primary example, it is Fiesta time here in San Antonio, which is a couple weeks of celebration, people coming together to really, really enjoy themselves. So with that, the team went ahead and pre-positioned push packs to stage in certain areas where the crowds are anticipated to be high, and to make sure that those life-saving products are where they need to be in the event we have an emergency and we need to respond to. And then the hospitals stand prepared to surge if necessary. Oops. Hold on. Okay, Diane, my slide is not advancing.
If that's not working, Leslie can take over and run your slides.
Okay, yeah, I'm not sure what happened. I can't get the next one to move.
So she will load that up, and you can just continue with your next.
Okay, sorry about that. And when you get there, it will be slide 8. And she's almost there. Okay, so just in continuation with our disaster preparedness, as we've talked about our Heroes in Arm program, which is what the program is called here in South Texas. The next step would be, what if we are unable to get that resupply to where it needs to be? Using my military background kind of also as a basis, there are times when the weather does not permit. And depending on the nature of the disaster, will the ground EMS crews be able to get where they need to get? So we are very excited about working on a protocol here in the background that we will continue to work on, which kind of takes it to the next level. And if we needed to collect in an emergency basis. So we're looking at it from a tier perspective, as you can see there on the screen. Tier 1 being the inventory at the time of the event. Tier 2, relying on our Burke partnerships to see if additional units are available to support the emergency, and if we can move those units, again, depending on the nature of the disaster that we're responding to. The tier 3 would be the emergency release of units here at South Texas that have been collected but may have not crossed the line for the lot release process. So emergency release of those units, which again have come from our steady donor base that actually support that program. And then tier 4, moving to an activation procedure for a walk-in blood bank, emergency blood collection type program. So again, very, very excited about heading in that direction and starting to work on what that could look like, where those collections would happen, and how that would be managed. If you could go to the next slide, please. And then finally, these are just some key steps that as we're thinking about a program and a process that we need to make sure that we really, really nail down. Exercise, again, the same coordination and collaboration that we have seen with our Brothers in Arms, Heroes in Arms program, and just the movement of the blood products now. That same level of coordination would be required if we're talking about any type of emergency activation collection. So from the activation processes to the recruitment to the actual collection, what type of testing will we do, and that emergency type testing that we can get done in order to ensure that the safest product is available to support an emergency situation? How will those units be transported? And then that follow-up to the donors and recipients if necessary. So again, these are just the key steps that we've outlined and where we'd like to go in our next steps. And just thought while we're talking about this program, what can we do to even make it better and more robust? Next slide, please. So again, I want to thank you all for the opportunity to speak here this afternoon and share very briefly our experience here at South Texas Blood and Tissue. And before I introduce the next speaker, I just wanted to highlight that from what we can tell, we have approximately 60 agencies across all 50 states that are actually participating in some type of pre-hospital holding and transfusing of blood products. So that could be the low titer Rojo blood, red cells, and a plasma product. So again, thank you for allowing me the opportunity to share in our experience. So it is now my pleasure to introduce Mary Homer, Chief and Project Officer at U.S. Department of Health and Human Services.
Thank you, Audra. I appreciate it. And thank you for all the organizers for allowing me to participate today. It's my absolute pleasure. Been a long time collaborator with the blood industry and on very important projects, including transporting blood to Puerto Rico under Zika and the convalescent plasma program during COVID. So happy to be here today and a strong advocate of trying to help the blood industry through all of the hurdles, the issues that they may confront in the future. Bottom line, I don't have slides. Work for the federal government. It takes 30 days for clearance of slides. So I will talk at you for a little bit, and then I'm going to hopefully leave more time for the Q&A for your own personal reference of how you might be able to partner with us. It will be more productive to do more one-on-one conversations. So bottom line is, I'm the branch chief of the Radiological Nuclear Countermeasure Branch. We'll come back to that at the Biomedical Advanced Research and Development Authority. We are a federal funding agency. That's what you have to hear. And we're interested in helping the blood industry work through some issues. So BARDA is a very effective federal agency. We have structured ourselves to run sort of matrix teams where once we decide on a partnership with a company or an organization, we provide the project management, the funding, manufacturing expertise, regulatory expertise, clinical expertise, non-clinical expertise. We have touched more than facilitated 71 approvals, which is almost unheard of in the product development industry. So our model is clearly working. so why RADNUC? Why is the blood portfolio in RADNUC? So when we're specifically tasked with helping the nation prepare and respond to threats and pandemics. The threat that is going to result in the largest deficit of blood products will be a nuclear detonation, which is how it got housed under us. So that explains that. Hold on a minute, I'm sorry. So what are the things that we're interested in doing? So some of the projects that we are currently funding, we're looking at next generation blood products. That includes, platelets, plasma, red cells, oxygen carriers, any of those sorts of products would be ones that we'd be potentially interested in. Platform technologies such as pathogen reduction. We have funded multiple pathogen reduction technologies. And we're also interested in, the thing that we're probably most interested in is working with the industry to figure out, with the way that it's structured, how can we build surge? Because if something bad really happens, if nuclear detonation really happens, we're going to need a whole lot of different blood products in a relatively short period of time. And it's not an easy problem, and it's going to take a lot of thought, and it's going to probably take more than one solution running in parallel to answer the question. I did present at the most recent ABC annual meeting. I actually put the requirement, or at least a published requirement, up on the board, and didn't get a lot of response to it because it was jaw-dropping in terms of the number of platelets that we would need within 2 weeks of a detonation. So really want to hear from the industry, really want to talk to you about ways that we can improve sustainability, availability, and prepare for, mass casualty events. When I say mass casualty, it's not some overwhelming one emergency room, it's hundreds of thousands of people. So I put my contact information in the chat, and it's easy enough to remember. It's my first name dot last name at hhs.gov. So what I would ask of you is that if you have a blood product or a project or something that you think might be transformative for the blood industry, I really want to hear from you. So just shoot me an email and we can set up a discussion and figure out whether or not it's the sort of project that would fit within the BARDA portfolio. And I ended on time, even though Audra cut into my time. So back to you, Audra. Thank you.
All right, sorry about technical difficulties this afternoon. Thank you so much, Dr. Homer. Next, we will have Eric Bank, Assistant Chief of EMS, Harris County Emergency Services District, number 48.
Hello, everybody. Good afternoon. Thank you to ABC for allowing me to do this presentation. This is kind of more of the boots on the ground view where we're looking at ground-based EMS. Okay, so I'm the Assistant Chief of EMS for Harris County Emergency Services District 48 Fire Department. We're a west suburb of the city of Houston. Unfortunately, we can't come up with a shorter name. I have no financial disclosures. I may mention a product or two that we use, but don't receive any endorsement or compensation for those products. So this is who we are. We're suburban of West Houston, about 55 square miles, 175,000 people. We're classified as unincorporated Harris County, if that sounds unincorporated. We do about 12,000 ambulance calls per year. I have 6 ambulances with an EMS supervisor. That's where our blood products live, is on the EMS supervisor vehicle. And those are my 2 medical directors who graciously allow us to participate and do this process. So home of the 2022 World Series Houston Astros, and also home of the busiest level 1 trauma center in the United States. suburban West Houston is 29 miles away or 45 minutes to the closest level 1 trauma center with no traffic. I do have a local level 3, and we have aeromedical, which is quite busy. And also, if you know, with this, our Gulf storms that pop up out of nowhere, sometimes they're just not available. And so that's what kind of drove this project a few years ago. So the EMS space is a little different. We can't control the EMS space. We can basically come in and mitigate the circumstances. We can't control the cause, but we can dictate the solution. This is an active shooter event that was a few years ago at Santa Fe High School. These are the types of calls that we face every day, and it's not a nice controlled environment. This is the environment that we work in. As you can tell, it's kind of limited space, but this is the space that we own and we can control. So let's talk about a few patients. So it's 1994. I'm sure people recognize that famous bell there. So in the city of Philadelphia, an adult male patient, he's about 30 years old. He's semi-conscious. He's cool ash and diaphoretic, pretty obvious hemorrhagic shock. He's got some pretty nasty slashing injuries. And what do we do for this patient? It's 1994. So 1990 trauma care is diesel fuel, so we can get to the trauma center, some Curlex, the 14 gauge IV catheter, and 1 or 2 liters of normal saline. Probably not the most efficient care for a trauma patient, especially a penetrating trauma patient that's actively bleeding. So if we fast forward a little bit, and the picture looks kind of familiar there, we're to 2014, so 20 years later. We go to a multiple shooting, very similar patient, very obviously in hemorrhagic shock. The patient has a single gunshot wound that transverses through and actually hits his femoral artery and transects it. There's no active site bleeding, but we know he's bleeding and he has no other injuries. So we reach into the bag and what do we have? Diesel fuel, Curlex, 14 gauge catheters, and 2 bags of normal saline 20 years later. We are fortunate to have wound packing and hemostatic gauze and tourniquets. In this particular case, this wasn't extremely helpful because this patient had a very high femoral injury that was very difficult to get to. So this leads us to what we see, or why are we seeing trauma patients die? And ultimately they die from coagulopathy. The blood no longer clots. And what leads to that is metabolic acidosis. So the patient gets acidotic, the circulating volume doesn't have as much oxygen. They're cold. I know that sounds a little crazy in Gulf Coast, Houston, Texas, where it's a balmy 85 degrees outside today. But if this patient is inside and actively loses a liter of blood and is on a cold concrete floor, they're going to be hypothermic. And then again, we end up with coagulopathy, and each of these arms kind of lead to ultimately the demise of the trauma patient because we can no longer get them to clot. They lose their complete coagulopathy. So if we look at crystalloid, which is the gold standard across the US, essentially that is the trauma triad I just described in a bag. So if we reach into an ambulance anywhere pretty much in the southern portion of Texas, that saline is going to be 76 to 78 degrees in the back of an ambulance. So we're already starting out cold. Now we're going to get colder. The pH of normal saline is 5.7. So now we're going to get more acidotic. If you do happen to have lactating ringers, it's a little bit better at 6.4. But of course, blood products are great because they match what we need at 7.4 for pH. Normal saline or lactating ringers have no coagulating factors at all. We do have TXA. TXA works okay, but blood products work better. And blood products contain clotting factors. And if we have whole blood, that adds platelets to the game. So crystalloids and the trauma triad are not a really good mix. So when I sat down in 2014 after dealing with this patient 20 years later, I had to sit and ask myself, does this make any sense at all whatsoever? So in 2014, we started the battle for pre-hospital blood. So this took a little over a year and a half to get up off the ground. This was actively being used in the military, actively being used on aircraft. in 2016, we had an excellent presentation and an excellent white paper done that looks at the national trauma system and how the pre-hospital military and pre-hospital EMS systems are aligned more than they have been, but we're still not quite where we need to be. And so this started this process for us back in 2014. So how did we get there? In a space that really had nothing similar in the country except for aeromedical. So obviously we had to talk to the medical directors. We're very fortunate that Texas is a delegated practice state, so we didn't have to go talk to the state. There's no state issues, there's no scope of practice issues. We had to work with our regional hospitals or the blood bank. So the hospitals initially told us no. Fortunately, we were able to partner with Gulf Coast Regional Blood Center. And thank you to my good friend and colleague, Dr. Hartwell. I'm not sure if she's on the call today, but she's one of the physicians over there at Gulf Coast Medical Center. And then what do we do with this, right? So how do we develop logistics and maintenance and be a good steward for the blood supply? How much are we going to use? What are our guidelines going to be? How do we replace it? Who's going to pay for it? How do we hand off patients? Can you bill for it? So again, kind of a pretty open space that really didn't have much in it. So we were kind of starting from scratch and working with our military partners. And from concept to inception, this was just over a year-long project to actually get this to the point where we could actually put initially component therapy out on the street. So this has been used in the military as far back as World War I, commonly used later in the Iraq, Afghanistan theater. We saw this transition to helicopter EMS. This is an old slide. I apologize. Lifelight has utilized this for much longer than 3 years. We made our request in early 2015, and we were able to deploy liquid plasma and initially Rh negative red cells in February of 2016. And we were able to transition this to low titer oil whole blood in August of 2017, just around the time Harvey came to visit us. So that's a pretty easy date to remember. So we look at this now, and as we try and expand this across the country, and as Audra pointed out, there's 60. My colleague and I, Randy Schaefer, worked on this yesterday and figured out that we're closer to about 70. And when we look at some of the folks that are selling some of the functional equipment that goes with this, it's probably much higher than that. But that's the list that we actively have. And so there's kind of three main functions. And the first one is medicine. Is it the right thing for patient care? Absolutely. But we run into a paramedic scope of practice issue across the country. It's different in each state. The logistics of daily operations. So how do we properly care and cool stored blood? As my light goes out of my office. There we go. Safe patient administration. Of course, we want to be good stewards of the blood supply. We don't just want to draw blood from the blood bank. It sits somewhere and then we don't use it and just throw it away. That's not a good stewardship of the blood products. And then how do we manage it? How do we manage the donor side? How do we distribute it and supply it? And how do we make sure we maintain a full effective life cycle of blood? And our colleagues at South Texas Tissue have done an outstanding job with those. So the medical issues we look at is, of course, we talked about scope of practice. There is a national scope of practice. There's a state-to-state scope of practice, and then there's the DOT-based paramedic education modules that currently don't include any blood products. And then when you look at the medicine side, what blood products are we going to use, and can we be flexible? How do we deliver it to the patients? How do we work with rural agencies who don't have the same amount of volume and need to swap blood more actively? Of course, when we deal with female patients and O positive, we looked at that. There's a lot of good data on that. I'll kind of touch on that here in a few minutes. And then we had to train our staff to make sure that we knew what the different levels of transfusion reactions were and how to address each one as they kind of came up along the way. Logistics is the one that'll kind of drive you nuts. The medicine is very solid. We need availability. What are the costs? When I say flexibility, we typically carry low titer O whole blood, but on days that it's not available, if there's an MCI or something, we can very easily switch over to component therapy, which would be liquid plasma and actually now Rh positive red cells. And then we need to actively monitor the blood life cycle and know how we're using the blood effectively. And there's costs, there's capital costs, there's actually the cost of the blood. Currently, this isn't recognized by CMS, so there's no reimbursement at that level. There's very minimal reimbursement at the commercial insurance level. And then for those involved in the hospital, so there is some hospital replacement, but there also are issues there too, where the hospitals don't necessarily want to replace blood products. They have to have faith knowing that the products are getting in from the street have been taken care of. So that's kind of working its way through the system on the logistics side. And we're pretty focused on trauma, but I also want to kind of highlight that we do use this for medicine-based hemorrhagic shock. Symptomatic bleeding regardless of cause needs to be treated. We initially added this guideline because we figured, boy, we'd look really dumb if we didn't have a medicine guideline for all these trauma patients we're going to save. And at the end of the day, it's almost a 3-to-1 in our typical population here in the Katy area from medicine to trauma patients. And that's the GI bleeds, excuse me, OB complications and bleeding. So again, this kind of raised the question of female patients with low titer whole blood transfusions. And so we actually vetted that. There's a very low risk in there. There's some great papers on that. Low titer whole blood across the country at a titer of 256 has pretty much become the standard. And so in September 2017, and I always put we believe because we don't know for 100% for sure, that we performed the first whole blood transfusion in the US in a civilian ground ambulance. And this was a mid-30s female with a sync blood episode while shopping. She's 2 weeks postpartum, grossly hemodynamically unstable, pale, she is hypothermic. At this time, we actually still had an active point of care lactate meter, which is no longer available. She had difficulty catching her breath. She had vaginal bleeding times 2 weeks. She was obviously in hemorrhagic shock. The reason that she was recognized is she would walk through the store where she was at and she would just pass out, stand up, walk a little bit more and pass out. The patient received 1 unit of 570 mLs of warmed low titer whole blood. And her syncope resolved, her hemodynamics got extremely better, her color improved, her temperature improved. Almost to the point when we walked in the emergency room, the doctor's like, why are you guys here? So a pretty astronomical turn of events. And that's what we see with the medicine patients is the paramedics actually see the patients get better and the trauma patients survive. So there are two pretty big caveats when you look at these two different classifications of patients. Trauma care today is improved greatly. I mean, as you can see with the Stop the Bleed program and some of the different medications, blood warmers, TXA, antibiotics, blood products, chest seals, and all the stuff we learned from the TCCC and our military partners. Some of the fancier XStats, easy IO access if we can't get IV access. Tourniquets are becoming a standard where you almost see them, and I think you can buy them at most sporting goods stores at this point. But trauma care has changed a lot, but we still need to see the blood products expand through the country. It's the true life-saving product that folks need as we continue to move through. And our hope is that some of the next generation blood products like dried plasma products are available so we can get those on the street because they're pretty easy to maintain. So I always like to add this slide. So these are some of the questions we actually get in the hospital when we come in with patients. Or patients actually ask us, how do you know my blood type, or how do you know the patient's blood type? Did you draw any blood first, which has been a difficult task to overcome, but I think most of the hospital systems have worked through that. Most places don't take pre-hospital blood, especially for transfusion. Is that blood? That's one of my favorites. That's whole blood. There are several folks who do not understand that whole blood is actually a FDA approved product. Who lets you give blood, and where did your blood come from? So in summary, across the country, we've seen extreme changes in STEMI and stroke care, where we look at time as muscle with MI patients and time as brain tissue with stroke patients. We're still not looking at a great standard for trauma patients. The golden hour we know is not correct. It was a great standard when it first came out. Someone with severe truncal trauma, it's more like a golden half hour if they're not getting any type of blood product. We need to work to stop the bleed. It doesn't do any good to give blood products if we can't stop the active bleeding. understand the trauma triad, and now there's a trauma diamond. And like myself and several folks on this call, I saw my friend Bill Bullock is on here from San Antonio, who helped drive this through the San Antonio Fire Department. Be the voice of change. You need to be the voice of change for your community and get blood products out on the street. Be flexible. Low titer whole blood's not always available. Learn the process and seek assistance from others. I would say of those 70 folks that are out there, I've probably heard from at least 3/4 of them. I just got an email the other day from some folks out in California. I'm happy to help anybody that needs any assistance. I stole this from my friend, Dr. John Holcomb, fight like you train, because it doesn't make any sense to shift gears when you get back out on the street. We know this is a very effective and daily operation, as we learned from our folks, South Texas Tissue, and then I'll go back to that event there in Santa Fe here in a second, that the MCI and active shooter events are kind of key to this too, and we need to make sure we're getting blood products there. That event in Santa Fe, there was one of the school district law enforcement officers received a pretty catastrophic shotgun injury to his arm. They were able to get a tourniquet on it. It took them a little bit. He was actively bleeding in hemorrhagic shock, and there were 4 aeromedical helicopters on scene, and each of those helicopters had blood products to transfuse on scene. So again, as we look further down, it's not just daily operations, it's some of the larger events that we have to deal with as well. I thank everybody for your time. I thank the folks at ABC, and then my colleagues I know that are out on this call as well today. And I'll be happy to take any questions as we move here towards as we get towards the end. Let me see if I can get that out.
All right, thank you so much, Eric. Next, we will have Dr. Jennifer Holter, Professor of Medicine in the section of Hematology Oncology. She is also an Adjunct Associate Professor of Radiation Oncology at OU Health.
Can everybody see my slides?
Yes.
Excellent. So thank you all for allowing me to talk about this. This is something that's really important to us here at the University of Oklahoma, and we really want to be the change that we need to see. And we hope we can take you through our experience here. As opposed to trauma, individuals in palliative care often have had a great deal of experience requiring blood transfusions, and are usually transfusion dependent when they come across that time period that they choose to go into palliative care. And during that time period, unfortunately, because often transfusion support is not feasible in hospice, they often will not enroll to hospice. There were several surveys that were done by hematologists that identified that 52% of patients were less likely to enroll. Because of not enrolling, they stay on active transfusion support and often come into the hospital for that transfusion support, making them 6 times more likely to die in the hospital or the ICU. You know, when I first started doing palliative care, I was under the incorrect assumption that hospices just don't have the ability to do transfusion care because it wasn't covered on the hospice benefit. That's not true. Hospice can provide transfusion benefit, but because of ease in scheduling it and transporting patients to and from for transfusions, and the actual cost of the transfusion, which eats up most of the cost of hospice care, they can't accommodate it. And like I said, 70% of hematologists don't feel comfortable in talking about doing palliative care unless we have access to transfusion therapy in individuals that are transfusion dependent. So when this was all kind of percolating in my career, I happened to be the chair of government affairs for the American Society of Hematology. And we took this on, and we wanted to make sure that people like me who are inappropriately thinking that you couldn't do palliative care transfusions, that we had a statement. And the American Society of Hematologists put out a supportive statement that said, basically, this is covered in palliative care and we need to find ways to make it happen. And you can see that on our ASH website. So what are the goals of transfusion in palliative care? Well, first and foremost, we want to improve quality of life, and we don't want to increase the work of the care for the patient, the caregiver, or the provider. We want to minimize transport to and from another site, because we know that can be difficult on all 3. We want symptoms to drive our transfusions, not that we that we run it similar to what we run transfusions in the outpatient setting, which is triggered by a threshold like a hemoglobin of 7 or a platelet count of 10. And what we recognize is that we have a lot to learn, and that knowledge is what will drive us to get better care for our patients. So with all this knowledge, I love the way I think Eric talked about that no is a word that we just don't understand, and that we are trained to care for patients, we need to do it correctly. So we wanted to say what is our ideal transfusion palliative care process? Well, we want to give the patient control, because if you don't need a transfusion and you don't feel like you need a transfusion, we shouldn't be giving you one. We want it to be symptom driven. We want to limit transport because these patients are very tired and need to spend the appropriate time with their families, not going to and from centers. And it should be very data driven so we can learn as we go. So being in the state of Oklahoma, I had amazing partners with the Oklahoma Blood Institute, as well as the Stevenson Cancer Center, and our local hospice group that wanted to be involved in instituting change. And so we created a home-based transfusion protocol that I opened. It was a clinical trial that piloted home-based transfusion. So we will send a nurse and the blood product out to the patient. It has 20 patients in it, of which we've currently enrolled 19. We looked at the literature that was available, and most patients on palliative care would receive 1 unit of blood and 1 unit of platelets in it every week. So we aimed at trying to hit that criteria. And what is unique about our program is we took the thresholds that we use and we threw them in the trash, and we said, we're going to go back to what our ideal is, which is let's look at the clinical symptoms and we'll try and improve clinical symptoms. So we have questionnaires that patients will fill out on fatigue, shortness of breath, bruising, and bleeding, so that we can make sure that we are actually improving their lives during the palliative care transfusions. I was not aware until I first started in hematology just how little time hematologic malignancy patients get on hospice. The average time on hospice for patients is about 3 days. It's not even enough time to just kind of get used to being back at home. Using our transfusion at home protocol, we've been able to lengthen that to almost 12 days, so 4 times as long. So they get longer periods of time. But remember, in palliative care, it's all about, is it quality or is it just time? And what we found was, on average, individuals only really received about 1.5 units to 2 platelets and 2.5 units of blood products during this time, but they got a lot for them. Their incidence of fatigue and dyspnea halved, or more than halved, in dyspnea, and in fatigue, it significantly went down. And keep in mind, these are individuals that are on hospice and have a very limited lifespan. And so these symptoms are going to increase over time normally when you're on hospice. And the fact that we could have any impact with decreasing these quality of life markers was really quite impressive. Not what I anticipated. I thought we'd have some stability. I didn't think that we could actually really truly improve things week to week. Probably as impactful is that these patients, like I said, were 6 times more likely to die in the hospital. Most of them will have to revoke hospice in order to go into the hospital. And most of them will die in the hospital if they have hematologic malignancies. On our particular trial, we had 1 individual that did get hospitalized for a fever, not for a transfusion. We had 0 admissions to the ICU. The patient that did get hospitalized was actually able to go back on the trial after they came out of the hospital for the neutropenic fever and was able to die at home. And this slide's a little bit outdated. We have 19 patients that are currently accrued, and all 19 have actually died in the home. So we've been able to prove that we can safely do that. Now, safety was the endpoint on this particular trial. So what you should know is that not one of these patients had a transfusion reaction while at home. That was done very carefully. I made sure that individuals that went on the trial did not have previous history of transfusion reactions or difficult to type blood or issues that would preclude them from being able to get blood in the home. And so we had absolutely no risk of transfusion reactions while in the home. And I will say, from the standpoint of things that I heard about this particular protocol, patients and caregivers and physicians are very reluctant to go on hospice when you have a hematologic malignancy, as I said earlier, because of a transfusion need. This gave them peace. They were able to go and get all the benefits of hospice, knowing that they weren't having to give up the transfusion support. And they were able to have better quality of life. One of our patients, who was the first one that actually went on the trial, said that it allowed the whole family to just basically take the dial down to about a 2 or 3 as far as urgency, because they knew that they could be safe at home. And that's the biggest word that I hear all the time. Am I going to be safe, or am I actually just going home to immediately die? And so I think our transfusion protocol was able to do that. Where I hope that I can go with this is we would like to develop a CMS project or some kind of project for hospice benefits that would allow us to provide this blood transfusion outside the hospice benefit that currently stands, so that we can prove that we can do this, and do this both for the betterment of our entire system, but also for the betterment, obviously, of the patients, as we've proven here. These are the patients, these are the people that have been kind of the forefront of doing these types of endeavors with us. And they include individuals that are from Duke and from Dana-Farber. Interestingly enough, Dr. Ori Oldehide is going to take our platform and is going to replicate it at Dana-Farber, so that we can enhance our experience and get that data that we've been wanting to go forward to. And that's all the information I have, but I'm more than willing to answer questions, and thank you for your time.
Thank you so much for that. Thank you so much for that presentation. And now I will turn over the presentation to Diane, Senior Executive Federal Government Affairs at America's Blood Centers.
Thank you so much, Audra. Let me get my slideshow going. So what I'm going to do is highlight what ABC is working on in this area, or these two areas actually, for today's topic of really expanding patient access when they need it most. So these really are two glaring areas where there are limitations on when patients can receive the blood. So I know that Eric did such a great job, and our other speakers in this area did such a great job of laying out, but there's a really robust pool of evidence, both military and civilian, that really demonstrate, first of all, how common traumatic injuries are that could lead to someone needing blood, but also, as Eric talked about, that need for getting that blood quickly to patients, and it no longer being the golden hour, but really looking at that half hour, and that need to quickly get the blood to patients to be able to really save their lives. And so what we've really been working on is getting that information out and available to the members of Congress that we've been working with. But what we're really working on is there are kind of 3 big challenges when we look at how can we get pre-hospital blood into more places around the country. The first one, this really is where our congressional ask is in the reimbursement area. So current EMS reimbursement is a bundled payment, and those payments are just insufficient to cover the cost of the blood. So, you know, at the high end for the most acute patient, we're looking at a little over $500 for that cost of the EMS care. And, you know, that 1 unit of whole blood takes up more than half of that bundled cost. And so just really making sure that the reimbursement is sufficient to allow EMS to be able to do this. Eric has been able to make it work. We have a number of other EMS providers across the country that have been able to make it work. But for the most part, they're able to make it work either through grant funding, through their local tax base that funds their EMS. And so what we've seen is that even some of the EMS providers that have seen really great results have seen people's lives saved because of the availability of blood. When a grant runs out, they may have to end their program. And it's really sad to see these programs going away because of the cost. The second piece of it is scope of practice. So state and local licensures differ in what a paramedic or an EMT can do. We are at ABC partnering with outside groups to really work and address this issue. And it's something we're working on. It's not really a congressional issue, but it definitely is a limitation that some areas have in terms of this. And we've seen some EMS providers get really creative in working around this. We have one that actually sends a physician out on the scene. So they actually take the blood out just so they can get that transfusion started. The final is the piece that our blood centers are working on. Unit of blood is available. So Audra did such a great job of talking about what South Texas Blood and Tissue is doing with their Hero in Arms program to make sure that they're available. So it's really that reimbursement piece through CMS that we're working on with Congress. So what is the ask here? And it's to expand access to pre-hospital blood in that emergency setting through the use of a CMMI demonstration program, that Center for Medicare and Medicaid Innovation, and really allowing it to be tried out to prove the concept, to take what our research studies that have been demonstrated, what a lot of EMS providers will tell you they've seen anecdotally, and turn it into the type of data that moves policy at CMS. So the next piece of it, moving right on to the hospice, and Dr. Coulter did such a fabulous job of really talking about what they are doing, but they are one provider in a country where a lot of patients need this access. So for those of you who are familiar with hospice provides comprehensive holistic care, not just for a terminally ill patient, but for their family and caregivers as well. When the hospice bundle was initially created, it was created with cancer patients in mind. Over time, over the 40 years that hospice has been around, we've really seen that bundle tailored less to those cancer patients and tailored more to those with Alzheimer's, just because that is the majority of those who are dying in the hospice program. And the reality is that what we're seeing, and this was really shown out in the data that Dr. Coulter shared, that those cancer patients, such as those leukemia and blood cancer patients that she works with, really are not enrolling in the program because they fear not having that access to those needed palliative transfusion. What we know is that hospice decreases not only the cost of care at the end of life, but most importantly, it improves the quality of life, and not just of the life of the individual that is dying in the hospice program, but also of their family and caregivers that are impacted. So hospice, as was pointed out, can provide transfusions, but they almost universally do not. And part of this is, again, a funding issue. Part of it is just capacity. We have small rural providers of hospice care, and it can be a challenge for them to provide this sort of treatment. And so what we need is a way that all hospice providers are able to provide transfusions for the patients that they serve. So getting a little more into, and I know Dr. Coulter did such a fantastic job of talking about this, but that delay that we see in those cancer patients that do rely on necessary palliative transfusions. Leukemia patients, as was noted, are likely to spend about 3 days in hospice. This is compared on an overall average of Medicare patients, and something Medicare has really been working on, of almost 90 days. That's a huge, huge, huge difference. And the difference really is that need for palliative transfusion. And what we see is that instead of dying at home in the way that the patients want to, instead of their family having the support that they need, what is instead happening is those patients are ending up in the ED, they're ending up in the hospital, they're ending up in the ICU. And so what happens is we're getting a lower quality end of life for that patient at a much higher cost to Medicare. And that is a tragedy in so many ways. So what we need to do is expand that access. CMS, the Center for Medicaid and Medicare Services, sorry, I've just thrown that out there without defining it, really has been looking to address this issue, as was mentioned in their 2022 rule. They did affirm that hospice providers can provide transfusion services. But again, for a lot of reasons, this is not practical. In their 2024 rule, they have recognized that, in fact, even though they can, hospice providers are not providing those transfusions. And so they have specifically requested comment on this issue and how they can better serve that patient population that does need those palliative transfusion. ABC, as well as others in the blood industry, are working together and ASH on comment letters to make sure that we are getting the information, the correct information to CMS. However, we don't have a solution through CMS. So what we still need is congressional action. And so again, this gets back to the ask here. So the ask really is for another demonstration program that would allow for the blood transfusions to be provided outside of the hospice bundle to make sure that they're available to all patients, whether through a hospice program like Dr. Holter's, where they're able to provide it through the program, or whether it be through a hospital transfusion service, that all patients that need are able to enroll in hospice and get the benefit of that program, but also receive the blood transfusions that they need. We do anticipate that there will be a bill dropped sometime soon. Senator Rosen's office has introduced a bill last Congress. They are planning on introducing it this Congress. Unfortunately, the staffer has been out, and therefore when she returns, they are anticipating on dropping that bill. We've also been working with some House offices that are very interested, but really just informing staffers. This is just kind of a niche issue that a lot of them haven't heard about, and it's not something that most people think about. And so really, this is an area where a lot of education is needed of Capitol Hill. So what can you do? This isn't work that the blood industry can do alone, that blood centers can do alone. This is really why we're having these calls, is to really reach out to you and give you the tools that you need to be able to make a difference. So this really is about the needs of the blood supply, but those patients that rely on it. So what can you do? You can support the advocacy changes. So if you go to our bloodadvocacyweek.org website, you can fill out and submit a letter to your member of Congress. You just have to put in your address. It pre-populates with a letter. Then you can personalize it, tell your story, tell why this issue matters so much to you, and it will be automatically sent to the right members of Congress for you. You can be a social advocate, share this issue, let people know. We have great graphics that are available on that Blood Advocacy website, Blood Advocacy Week website. You can share those on social media and make more people aware of the issue. For those of you who represent an organization, we're going to be organizing some sign-on letters to Congress that organizations can sign on to as well, and those will be coming out in the next couple of weeks. So thank you again for participating in this event. I want to remind you that we have one more event coming up tomorrow. It's about life, why donor diversity is critical to patient care. So again, that focus really on the patient. So I want to encourage you to join us tomorrow for that event, and I will turn it back to you, to Audra Taylor, to wrap a few things up.
All right.
Actually, jump to Q&A. Sorry, I'm getting ahead of myself.
That's okay, Diane. Actually, that is exactly what I was going to say, that it is now time for Q&A. Please type your questions and comments into the chat, and Diane will fire away as they appear in the chat.
Yeah, so we have a lot of really great questions already in our Q&A box. Keep them coming. So the first one's actually for you, Audra. How are dedicated donors recruited for the Hero and Arms program? Are longtime O negative whole blood donors converted into that program, or how does that process work?
Yes, actually, great question. So thanks for asking that. First part, our target, of course, are our Group O donors. And with the start of the Brothers in Arms program, of course, that was for male donors. So the O positive male donors, as they present, we would be checking that titer level. And if they qualify for the program, then they would kind of get that introduction, and we would extend that offer for them to join that program, and then work on them to schedule their follow-on appointments. With the addition of females, of course, the pregnancy status is included in that, but also the Group O females are now a part of that. We're checking the titer levels in the background, and then following the same kind of introduction, kind of pulling them into the program. O negative donors, we do not have them participate in this program because we all understand the need for O negative blood donations, for other specialized patients. So they are not included in the Heroes in Arms program at this time. Thanks.
Thanks so much. So the next question is actually for Eric. You mentioned working with other EMS providers, and I just wanted to know what you are hearing from other EMS providers that are interested in this area, what they see as the biggest barrier to getting a pre-hospital program started. I know the questioner said that they've worked with some EMS and have gotten kind of a no thank you sort of answer, but they haven't really gotten the details on the why.
Yeah, so again, it kind of depends on, of course, is it a scope of practice issue? Is it a financial issue? Is it a medicine issue? So I mean, it's best to keep knocking on the door and find out what the issue is and then work to resolve it. There are several of us on this call and then several across the country who are happy to help anybody through this process, from the blood bank level all the way to the boots on the ground level, to try and get this out. And for us, when we first started, there's a few agencies around us who now carry blood products as well, but we're also always willing to go into our mutual aid partners around us and provide blood products. So it's just kind of, don't take that no for an answer, and kind of figure out where your issues are, and then try and work through those, and then always ask for help and see if we can help drive or guide that process.
Thanks so much. So the next question I've got actually is for you, Dr. Holter. You talked a little bit about how the patients and families responded to the addition of blood transfusions. How did the hospice workers respond? And did you have any kind of pushback, or were they happy to see the transfusions?
So I will say, you pick your audience, right? So I had an audience of a hospice group that was heavily involved, and really wanted to see this go forward. So they were very excited. And we didn't ask too much of the hospice group other than to assist us with doing the quality of care surveys. So we didn't add too much to the hospice work that they provided, and allowed them to focus on taking care of the patients. And so they really did appreciate it.
Fantastic. So I think we have time for one more question. We're kind of pushing up on the hour already, but I have one final question for you, Dr. Homer, if you are still on. Is she still on here?
I'm
okay.
still here.
Okay. You had disappeared from my screen for a moment, so I just wanted to make sure. So you brought up the nuclear aspects of it, but how do you see those projects that could be helpful and useful in a nuclear disaster or pandemic also being helpful in kind of the more likely everyday events, things like that pre-hospital use and other ways that those products can be used?
Sure. So generally, any products that are in everyday use and familiar to the end user are going to be more advantageous in a mass casualty event. It's important to have the end users, the people that are actually going to be using them, familiar with the product. So not only that, but another premise of our portfolio management is to try to make sure that when we invest in a program, that it's going to be commercially sustainable. So what we ultimately are shooting for are products that we can get across the line that will then be in everyday use. So when we're talking about blood products, we're hoping that these things are in everyday use. So classic example are the dried plasmas. We really want to get those across the line. We want them to be forward deployed, out into the remote areas that don't normally get blood, and to be readily available on shelves, so that they're already positioned if something happened. Whether or not we'd stockpile, that's a separate question. It's possible that we would stockpile something like a dried plasma, but not a whole lot of it. Does that kind of get to the answer your question, or does you need more information?
Yep, I think that definitely answered Well, I think we are out of time for Q&A. So Audra, I will turn it back over to you to let you wrap up.
Okay, thank you. Thank you everyone for participating in our virtual event today. You can help by reaching out to your members of Congress to let them know about the importance of ensuring access to blood products for pre-hospital and hospice patients at our Blood Advocacy Week website. This simple action will only take a moment of your time to let Congress know just how important reaching these donors are. If you have any questions about Blood Advocacy Week or any of the advocacy actions, please contact Mr. Jeff Goinger, Director of Strategic Communications and National Partnerships. His contact information is available in the chat. Thank you again for participating in this event. We encourage you to visit the Blood Advocacy Week website to register for other Blood Advocacy Week events and learn easy ways that you can help. Thank you so much.